emulsify the heminucleus. Please note this is a technique which is very safe for soft nuclei. In harder nuclei, you must make sure that the endothelium is protected very well with viscodispersive viscoelastics. So once this 3-piece IOL is safely now guided into the sulcus, because you do the clearance of the cortex, and now the same IOL that has served as your scaffold is implanted into the sulcus. The AC is clear of vitreous, and this is how the patient looks like at the end of the surgery.
23 gauge micro
I'll
incision
just stop here. Thank you
cannula
for your
system
attention.
forms the backbone of this instruction course.
Thank you,
It is
Dr.
imperative
Ritika,
to
for your
understand its component
presentation.
and
It was
usage to
great.
fully
I would now
utilize the
invite Dr.
tricks shown
Partha
in this.
Biswas to please come up, and he'll be talking to us about the PCR and posterior rhexis. Coming up to Dr. Ritika, I think the videos were excellent. They were great teaching points, and that you should avoid putting a one piece into the sulcus, and the way she showed the femtocataract and the difficulty with levitating the nucleus in the femtocataract. So I think these were all very clinical points, and which surgeons they usually come across, and please do take a note of all these things, because even if you get 1 or 2 tips which really help you out in the procedure, like, it's worth being here. Thank you, Dr. Ritika.
Much. Good morning to every one of you who is present here in this hall, and thanks to Dr. Priya, Dr. Lalit Verma sir, for giving us this opportunity to be here in Gurugram early this morning today. So I just remembered that in my first day of residency, when I went to my HOD and he was in the theater, and one of my colleagues, a fellow resident, he asked my HOD, very, very aptly, he wanted to learn. So he said that, sir, you're doing a cataract surgery. What happens if you do if there's a PCR? So that was his first question in a residency program. So sir looked up and said, "Shubh shubh bolo." The next day, again, he wanted to show off his guts, and he said that, "Sir, I have learned everything about PCR, and I just want to know that if there's a nucleus drop, what to do." Sir said, "Just get out of this room." So this is what happens, and early morning today, so we start with shubh shubh bolo. So, so converting, so the only shubh that I can think of in a PCR is converting PCR into a PCC. If we can make a PCR into a posterior capsulorhexis, the shubh has happened. So let's look at this. जब शुभ हो ही नहीं सकता है, there is a large PCR, a nucleus in the cortex, and can someone come and just put the sound cord, please? So the nucleus is there in the anterior chamber, and what needs to be done, and Ritika showed the IOL scaffold, which is an excellent technique, but also if we can separate out the nucleus from the anterior vitreous that is very much there by dispersive viscoelastic, placing the whole layer of dispersive viscoelastic, and then removing the nucleus by very gentle phacoemulsification, replenishing the viscoelastic time and again till it is very much there, and you're seeing that the nucleus is not going down. The anterior vitrectomy is a very important step. The anterior vitrectomy has to be done well, and the vitrector has to come in from the side port and not from the main port. Therefore, you have a closed technique and an anterior vitrectomy to be done. The intraocular lens, in this case, we placed it over the sulcus, and after placing it over the sulcus, you can capture it in the anterior capsule. And once captured in the anterior capsule, this is a very, very stable situation which stays on and on. And of course, there's vitreous in the anterior chamber, and whatever vitreous is there has to be removed by good anterior vitrectomy assisted by tricot. Let's look at the next situation, and when PCC is possible. So this is a very, very important solution, and here we are, and we have completed the removal of the cortex, and then as we remove, we suddenly find that there is a small PCR, and this PCR is central. When such a thing happens, and possibly it was just removing that irrigation aspiration cannula that it happened. So by this side port, putting in dispersive viscoelastic, having a nice inflated anterior chamber, and then going with the microrhexis forceps to carve out a very nice and a neat posterior capsulorhexis. This is an ideal situation. If we can achieve this, the Rome is won. But it's not achievable in every case, and therefore we have to understand that every case has to depend upon its merit. So this is a single piece lens which can go into the bag. This bag is a stable bag. It will not move out, and the posterior capsule is well taken care of. So it's also important to remember that when we put in the tricot, the triamcinolone, this should be just enough to be in the anterior chamber, should not go into the vitreous cavity. Otherwise, you have a huge blob of triamcinolone in the vitreous cavity, which best be avoided. Now let's look at this situation, and you can see that I've had a real tough time, and we've put in 5 hooks here, and these 5 hooks, and I've had a PCR. Now with this PCR, trying to take off posterior capsulorhexis, and once the posterior capsulorhexis is done, then what, as we can see, that the iris is popping out and there's vitreous very much in the anterior chamber. But with this amount of vitreous in the anterior chamber, a good anterior vitrectomy needs to be done. And if a good anterior vitrectomy has been done, then the vitreous traction on the base of the vitreous is relieved. Why is it important that we should do a good vitrectomy? It's to relieve the vitreous traction on the vitreous base, number one. This was a small pupil. If someone cannot see through the indirect in the periphery of the retina, this has to be taken up and has to be seen very well in the post-operative time. The post-operative recovery is usually a little late. There can be a lot of corneal edema, but these cases, vitreoretina evaluation is 100% must. So once that is done, then the next part is easier, and we can place the intraocular lens in the bag, tricot assisted vitrectomy of the anterior chamber, and you can see that there is quite a large amount of vitreous in the anterior chamber. So again, if it is a small pupil, the pupil has to be well out of the way. If it is not well out of the way, visualization of the anterior capsulorhexis, visualization of the triamcinolone becomes difficult. So in all these cases, if the patient is under topical and you're not comfortable under topical, you can give a little bit of peribulbar injection, and that has the patient well controlled for a longer period of surgery. So let's look at this case in which we have a PCR with the nucleus and cortex, but the nucleus and the cortex is not much. So once I have detected the amount of PCR, so what I'm doing is placing this dispersive viscoelastic, and then we still are able to retrieve that posterior capsular rupture, and I can make a PCC out of this posterior capsular rupture. We do have a fragment of the nucleus, and we do have a little bit of cortex over there. So placing in and removing the cortex very gently, trying to see that the vitreous is not disturbed. If the vitreous comes into the anterior chamber, this is the time that you have to do a vitrectomy. If there's vitreous into the anterior chamber, vitrectomy is a must. If vitreous is not there in the anterior chamber, then you can remove the amount of cortex by the bimanual as well. So you can see that there is still a fragment of the nucleus there, but I wanted to place the single piece intraocular lens in the bag, and therefore went ahead with this part of the procedure, placing it in the bag and placing it so that this forms a scaffold for that nucleus fragment that is there, and it's a small fragment which we can take off. So again, we have the benefit of a posterior capsule which is quite stable, and once removal of this little fragment is done, then the vitrectomy needs to be done, and once there is no vitreous in the anterior chamber, we can get ahead with it. So I come to the last 2 small clips of the videos, and this is If there is a posterior capsular rupture, this was a PPC. Can I just take 2 minutes, Priya? 2 minutes. So this is a posterior capsular rupture, and you can see that this posterior capsular rupture is through and through transverse. And I would like to tell you that this is a very important technique that can be done, not in all cases, but in some cases definitely. In this case, I'm going to stop here and think, can we place a single piece lens in that ruptured capsule which is torn right from side to side? Yes, we can, with a little bit of technique, a little bit of expertise. Now just watch what we are trying to do. So we have the anterior capsule well and round. The posterior capsule has ruptured transversely. What we are trying to do is, the first step is placing dispersive viscoelastic between the ruptured posterior capsule and the anterior capsular rim. So the space is made out. So once the space is made out, we land the single piece lens, the haptic of the first haptic is landed on the iris. And once it lands on the iris, we let it unfold. Once unfolded, then this haptic is just very gently twirled in, and it acts as a fulcrum, and it goes in between that space between the anterior capsule and the ruptured posterior capsule. Similarly, the trailing haptic is also done the same way. That space has to be maintained. If we are not able to maintain that space, then the haptic is going to go into the anterior vitreous. It is a little tricky, but if you have a very well-formed anterior chamber, if everything is stable, this is possible. And of course, removal of any vitreous from the wound or from the anterior chamber is a must. The last of my videos, and here again, this situation is one that it's a PPC, and again, I have had a posterior capsular rupture through and through, but this time it is different. So here it is a longitudinal rupture, and one part of the rupture is a little larger, one segment is a little larger, the other segment is a little smaller. So in this case, can we place a single piece lens in the bag? You can see that this part, the left part, this part is a small part, and here I'm putting that blob of dispersive viscoelastic to separate the anterior capsule from the ruptured posterior capsule. Again, landing the single piece lens over the capsule, in fact over the iris, letting it unfold. Again, placing viscoelastic so that we have a stable chamber, and then under direct visualization, we are placing this haptic in between the torn posterior capsule and the anterior capsular rim. We have to be 100% sure. It has to go a test. You have to see that it is well placed, and once it is visualized, it is well placed and it is stable, then only this lens can stay, and it can stay forever. Of course, we have to do a follow-up, and follow-up is not only for the anterior segment but also for the posterior segment to detect any breaks in the periphery, any treatable lesions in the periphery. So thank you very much for your kind attention, and thank you very much, Priya.
Thank you, Dr. Partha, for these videos. They were really great. Meanwhile, I would invite Dr. Lalit Verma to please be on the next presenter. There were great teaching points, sir, in your video. The way you do the posterior rexis, etc. It's very important. And I think one of the most important things for a newcomer who is venturing into doing a posterior rexis is, you try to have as much closed incision as possible, and then you try to venture inside and try to do a posterior rexis. Converting a rent into a rexis, it has got so many advantages that you probably would not even appreciate it, but actually it's really great to do that, first thing. Secondly, I think avoid doing all the swiping movements when you have a vitreous coming up, so with your forceps or whatever, with the rod or whatever you have, so, and then go ahead with a vitrectomy and clearing up everything. And as Dr. Partha brilliantly showed, that you can also put a one piece intraocular lens into the bag, probably if you have good space inside, and you can place the haptics inside, because you really do not want those haptics into the sulcus and rubbing and causing problems later on. So I think they were really very nice. Thank you so much
Thank you.
for being with us.
This, the last two videos that I showed cannot be done for every case by everybody. If you are confident that you can do it, please try. If you are confident that there is space between the ruptured capsule and the anterior capsule, then only to try. Because at times it's not possible, the vitreous has come in between and it is stuck, sticky, so it is not opening up. In such cases,